bicarb drip, bicarb drip. Sorry, let me click off that. He also gotten several boluses of bicarb as well. His pH was like 6.9 or something like that. On bolus of protonics and started octreotide drips. Pretty sick guy. Next slide. So this is what we found when we came in there after we got report. You'll see blood pressure wise, he's hanging right where he should be. He's only mildly tachycardic. Not sure what his baseline was. His end tidal was blown down pretty low, and you'll see his blood gas there, which was a couple hours prior to showing up. ABG was 6.95, 23, 442, and 6. So his bicarb was in the toilet. They had tried compensating with that. You'll see the vent settings. So they more than doubled his normal ventilatory minute volume to 16 liters. Just skimming through here. Access wise, he did have a triple lumen. He had the peripheral IV. He also had, I think I forgot to put that in there, his blood transfusion. I know one of you docs had talked about like making sure you have proper access. He actually had a dialysis catheter they had just placed to do continuous dialysis on him. And obviously they were using that for pounding blood products. So because he was decompensating pretty quickly. Neuro-wise, just nothing there. GCS to 3, not responding to anything, sluggish pupils, negative RAS on no sedation at all. You'll see his lactate, the rest of the labs there, lactate was 23.3. He had gotten some IV fluid as well. His calcium was 8.2. I did put his albumin in there. I think corrected for low albumin was like 9 point something, but regardless, on the low side normal. And that's probably before he got all the pack cells that he had since subsequently gotten. Down below, you'll see all the drips. So Levofed, not a huge dose, but also not a small dose either, pretty decent size. Vasopressin, as he was super acidotic. He had gotten several pushes of bicarb prior to us getting there, and had a bicarb drip to 3 amps in a liter, running at 100 mLs an hour. Also on the life-saving octreotide and pantoprazole. He did get calcium gluconate. We didn't realize, we had just asked if they'd gotten it. The nurse had said yes. And then once we had finished and were documenting, we saw it was only 1 gram of calcium gluconate. So that's something we could have potentially given more of. Patient also gotten some antibiotics and thiamine. So for us, in true stat medevac fashion, we switch everything to ASV. Doc was concerned about such a high minute ventilation, so you'll notice that we cut it by 2 liters from 16 to 14. That was at 200% minute volume on ASV. And part of that thought was that, patients, end tidal was in the toilet and her PaCO2 was also extremely low, that you're clamping down the vessels so much in the brain, you're no longer perfusing the brain. So we backed off on that and had given some bicarb pushes. No issues on the ventilatory wise. PIPs were a little on the high side, but tolerating the 14 liters a minute. And in the chart, it's kind of odd, even though he dropped minute ventilation by 2 liters, the end tidal never actually changed. It stayed in the teens, high teens. So you'll see 14-15s when we got to the bedside, 15:45s when we dropped the patient at Hopkins. So obviously it took us a bit of packaging time because the flight itself is only like 6-7 minutes. No real change there. We did have to titrate down the Levofed. The patient's blood pressure, obviously after he pushed a little bicarb, his blood pressure shot up. So to try to fix that issue, we had backed off on our Levofed, eventually down to 0.6 by the time we got to Hopkins. We got additional 2 units of pack cells and FFP that we had transfused during the packaging and also during the actual flight itself. And the bicarb drip, I think we bumped that up to 200 mLs an hour in addition to the 2 amps of bicarb pushes. Another thing too about transport we really had to think about was keeping the Blakemore to traction. Requires a lot of jerry rigging. So they had it hooked up like a string hooked up to the end of the tube, which was up on an IV pole, and hanging was a liter bag. So we just had to sort of jerry rig that to get that to stay to traction off the back of the stretcher, which we were able to do. I will say that when we arrived to Johns Hopkins, one of the nurses, I don't think realized the gravity of how important that traction was on this patient. She had taken the traction off, and I turned around and I looked back in there, and the patient only had blood bubbling out of his mouth. So I went in there and grabbed it and pulled it back down. And then actually Troutman ran up to the helipad, and we for stat medevac and Hopkins Lifeline at medevac 10 and all of the bases, we do carry 2 units of pack cells. We had not used our pack cells at that point because we'd been using the facilities, and obviously they needed blood ASAP. His pressures were starting to tank. So we ran up and got those 2 units of pack cells, and those were then transfused. And then when we went to go replace ours, we found the tech down there, and they're also activating their own massive transfusion protocol and headed up that way. I think that's it for transport wise. I mean, obviously, like thoughts that were going through our head. He's severely acidotic. Do we have another slide, Sam, that has the labs? No, okay.
No, that's it.
We drew another set of labs. They weren't much different. The ABG or VBG that we had seen, right? It was an ABG we'd seen before. He was still severely acidotic. pH was still less than 7 when we arrived and drew our own. Pretty sick dude. Again, we talked about the calcium. We probably would have given him more calcium had we known. He did have a central line, so we had carry calcium chloride. We could have given that. So something else I was going to mention, I forgot what it was now, but basically that's the big things for the transport. So if anybody has any pearls for us, that was me and Wayne on the transport. We appreciate it.
Thanks, Meg. Yeah, I think we've got some sort of expectations and considerations, and really this should be sort of pearls and points we want to talk about this case. So I think I've got a whole list of things, and I just want to sort of toss this out to the physician, medical director panel, and kind of have you guys discuss this and give your thoughts on the goals of care and sort of what you would expect your crews to be kind of working towards. Because a lot of these patients are outside of protocol, right? So a lot of this is not necessarily protocolized because it's impossible to protocolize every single patient. And to me, one of the most dangerous things in the world is trying to cram a patient into a protocol just because that's what it says. So blood pressure goal. What is your blood pressure goal? What would you want our blood pressure goal to be for a patient like this? Do we treat them like a trauma patient and sort of do that permissive hypotension, or is there other concerns for blood pressure?
So I would treat this like a trauma patient and allow for permissive hypotension with a systolic blood pressure goal of 90. And one thing I just wanted to add, and it's not something I considered coming from a place like Hopkins where we have all of the resources under the sun, but having worked with Lifeline for this last year, and some of the places we transport from don't often have the same resources we do. For example, I was working in a community hospital the other day that didn't have any platelets inside the entire hospital. So thinking about blood products and massive transfusion before we actually leave the sending, or Hopkins or University of Maryland, wherever we're dispatching from, because this may be one of those rare instances where we actually need to bring the blood products to the patient.
I mean, I would argue, knowing that this guy has underlying cirrhosis, a map of 55 to me is just fine as long as there's some evidence of tissue perfusion. I mean, I've often used sort of in austere environments a Marches type of protocol where you don't have a mental status on this guy, but a mental status and a palpable radial pulse tells you quite a bit beyond just what the blood pressure is.
So that's a really good point, and it's almost like this was rehearsed. I love these pearls. So the first of all is, let me just say, without knowing the outcome, is you guys are absolutely screwed with this case, right? I love the fact that we get these dispatches and these patients are so ill. I don't know how many times I review these cases and they say, why did you transport? And it's exactly as I think Dr. Kemp said, sometimes the decision is, yes, this patient is going to die, but they're absolutely going to die unless they go ahead and go somewhere where they can deliver definitive care. So I think that is one thing to consider, because honestly, there are some patients that probably should not be moved. If you can offer definitive therapy in terms of GI, general surgery, then that sort of tips the synthesis in terms of getting to move them. And then obviously it's a very complicated case. And I think that we're probably going to flesh out a couple of key concepts, but in the traditional critical care type of thinking, I would be very, I would encourage crews to think about how we can optimize each bit of this. So just for example, when we talk about bleeding, as you mentioned, this person is dying because they're not perfusing and they're actively hemorrhaging. So not only is there considerations for master transfusion, but calcium, because you're giving so much blood product. I think Cody Winifred mentioned TXA. Given the data on TXA, it's not great, but when your patients are at the end of their rope and they have nothing else and you don't have time to wait for a TEG and hemorrhagic shock, it's one thing you can optimize. And similarly, from the perfusion aspect, I agree that we need to be very careful about targeting objective blood pressures. Titrating to perfusion is something I think is excellent. I think the issue of bicarb boluses for patients like this, I mean, yes, they're very low, but this is a patient who's dying because they're exsanguinating, and it's very difficult to kind of catch up. So I would say the focus needs to be on hemostasis and hemostatic type of resuscitation. But lots of stuff there. I mean, very challenging call.
I concur with everything that's been said. I'm definitely on board with the hypotensive concept of resuscitation and targeted perfusion. It's very tricky in this patient. One, you don't have mental status, as we talked about, but two is this patient was certainly hypoperfusing for a while. Look at what their lactate was, right? So, you're already behind the 8 ball here. I'm on board with the maps of 55, 60. I would probably, have targeted a little bit higher, but still, certainly nothing more than a systolic of 90. And the other thing I'll say is keeping up with the minute ventilation is critically important here as well. One, you're giving them a whole lot of bicarb. So, you got to be able to blow that off. Two, their expected PCO2 is much higher than it should be based on what their bicarb is on that gas. So unless you recognize that, you're going to make them worse and you're going to make their acidemia worse. And then, whatever pressures you're giving them with whatever catecholamines may or may not be working, is just going to sort of spiral out of control. Also on board with the TXA, I think it's a great option here, especially as this person is critically ill, exsanguinating, and you need to be able to get them to definitive care, as we all said.
Hey, Asa, what did you mean about making people worse? Could you expand upon that for those of us that are fans of the acid-base disequilibrium in this patient? I'm just curious.
Yeah, so, you could get, obviously this person has a rip-roaring metabolic acidosis. If you don't understand where their expected PCO2 is, you can in theory give them a concomitant respiratory acidosis and prevent them essentially from compensating. Which will obviously drive their pH even lower and make it even more difficult for them to resuscitate. Remember, we think about this in trauma, but the triad of death, right, is there's acidosis in there. So if you're going to make their acidosis worse, you'll make them more difficult to resuscitate. They're already developing, obviously, a coagulopathy, and they're clearly, have a lactate already. So I think it's important that we remember that sort of triad of exsanguination and not necessarily like triad with respect to trauma, because it really helps give the entire clinical picture.
So I think everybody will agree that blood is blood, more blood. Dr. Launer typed it in the chat. More blood, give blood as fast as possible, give it faster than they're losing it type of option in this case. How important are two factors with the blood, that we're giving a balanced blood resuscitation and not just pounding them full of PRBCs, potentially giving the other components. And then how important is some sort of blood warmer, and that we're not giving ice cold ice cold blood? Like, and if you don't have a warmer, is no blood better than some blood? Sort of what's that risk benefit analysis?
I can start there. Great question. The other part of this triad of exsanguination is hypothermia. So we really need to focus on reversing their hypothermia. I guarantee this patient's going to be hypothermic. They're being actively resuscitated. They're getting lines. They probably are completely naked on the bed. Maybe they have one blanket over them, but we need to be cognizant of making sure that we do everything to keep them warm. And if at all possible, the product that we're giving them should be warmed. If not, we're going to continue to drop their core body temperature. If we're unable to warm it, yeah, I still think they need some product, because without the product, they're definitely going to be dead. But the temperature in the back of that aircraft, the temperature in the back of the ambulance should be set for the patient, not for you as the clinician. So we need to really be cognizant of making sure that we're on top of that other aspect of this triad and helping to not only prevent, but likely reverse the hypothermia.
Yeah, I'm also, this is well said too. I was also struck by the fact, Lucas had mentioned this earlier, the fact that this person was bleeding around the Blakemore even with a little bit of traction, and that's kind of the pitfall of the Blakemore. We tend to think that helps us achieve hemostasis, and this person is clearly continuing to exsanguinate. So this is part of this other equation where this person likely needs immediate embolization and surgery, because no matter how much bicarb you end up giving here, and this person's just losing like literally the entirety of their blood volume viscerally. So certainly a concern. So very sick.
Yeah, I mean, I hear that story with that Blakemore, I'm immediately thinking this is a GDA bleed or this is Gaves and they need IR. They need to be in a hybrid room.
Talking about IR for this guy too, just downstream stuff.
Ruben, Eric, anything to add?
I don't think I have anything. I think it's all been touched on. Very, very sick patient for sure.
How important is the FFP in this patient?
What was that, Sam?
How important is the FFP in this patient?
So I think, it's very important. If you give a bunch of red blood cells, but you're not replacing coagulation factor, it's just going to bleed. You need to replace product as well. It needs to be a balanced transfusion, because otherwise you're just never going to clot. You're going to worsen that coagulopathy.
Yeah, this is no different. Like I think we've all been saying it. This is no different than a traumatic hemorrhage, right? And all the same principles that we apply to the crashing trauma patient should apply to this patient. The triad of death plus calcium. They need 1-to-1-to-1 MTP protocol kind of thing. So we've all been saying, and this patient is treated just like a traumatic hemorrhage.
Ben put a comment in the box about whole blood. I think we really do want to move towards a whole blood type resuscitation strategy. But for all the reasons already said, balanced transfusion is really important to these people.
And Matt, we work at Hopkins, right?
Yeah, I know. The only way we're getting whole blood is if we do walking donor flight crews. I know.
We're not so far away from you over here, man. That stuff is protected unless you go to Pennsylvania.
So I want to move on to sort of the next point on my list here is this acidosis, and it's extremely. It adds a whole extra layer of complexity to this patient. They're already profoundly acidotic from that end organ perfusion for such a long time. The ventilator was kind of doing its best work possible, right? You're sort of on the top end of what that ventilator and the amount of minute ventilation we could give that patient. So we're trying to kind of supplement with bicarb. Does bicarb have a role in this patient? And is it just a temporizing measure to get them to that IR suite, to that hybrid room? And Asa, I know, mentioned that we potentially can make things worse with the bicarb. Can somebody talk to me about that a little bit?
Yeah, bicarbs. I'll take the bite. Bicarbs becoming more controversial. Um, you know, I think if you were mentioning about discrepancy between your CO2 and your end tidal and dead space and the pulmonary function. Someone with good lungs, they're going to be able to blow off that the bicarb component that you're giving them, and you will eventually get some alkalotic effect from it. But someone who you're behind on their minute ventilation, if you do have concern, for dead space from a pulmonary perspective, you may be getting into trouble, slamming them with the bicarb. This patient, if you're confident that they have good lungs, I think worst case scenario, the bicarb's not going to do anything. It may end up helping down the line as they blow off the component of that and actually start benefiting from it. But you can get into trouble if you're dealing with someone with bad lungs and you're hitting them with bicarb and they have a lot of dead space and they can't blow that off.
Thanks, Ruben.
I would add with the bicarb, I think we've all had the experience of giving someone an amp of bicarb and their pressure will almost always increase. And I think it's just worth that isn't always a direct effect of the change in pH by the bicarb. You're actually giving a fair bit of volume because of the hyperonchotic nature of the bicarb in the pushes, so you get some volume effect. But someone who's this acidotic, who may have concomitant hyperkalemia, I think a lot of times when you see the effect of the bicarb, it may not be the direct effect on pH as opposed to just the sodium load that you're giving the patient.
Because it's roughly 7-ish%, right? It's like giving 7% saline, 7-8% saline.
Exactly. So it's like 7.5% hypertonic.
Okay.
Yeah, I'll defer to the Hopkins bicarb expert over there, Ruben, which is great. And I think we think of this as a crutch. And I'm so glad that nobody here said, which I hope we didn't say, let's protocolize bicarb, because I think this gets to be a very difficult situation. I think in general, bicarb may have a role when you have these horrifically decompensated patients with a pH below 7.1, 7.0, where there's a profound metabolic acidosis and there's a need for temporization, but it does not come without a cost, obviously. But I think we have to be careful in thinking that bicarb is what's fixing this, because really the first thing to do is to figure out how we can at least prevent the damage that's going on from the ongoing hemorrhage, whatever the other insult is. And we've seen that sometimes it does not have a lot of benefit. So I'd reserve it for patients with, you're able to correct their minute volume, number one. And number two, you have some indications such as, a patient with, terrible metabolic acidosis and a pH that's indescribably low, lower than 7.1, and you're just trying to temporize. But I think it's very difficult to develop a guideline because physiology can be complicated and different depending upon what illness you're treating.
So the last thing that I think I wanted to touch on with this patient, and I'm sure we'll probably come up with something else, but the calcium thing. So calcium is becoming more and more sort of mainstream, and I think a little more accepted. And I've actually seen people take what we used to refer to as the lethal triad and make it the diamond of death with the addition of calcium. The hypocalcemia that gets triggered by massive bleeding, and then sort of the shock, and then we're transfusing and chelating the calcium and all that stuff. Can we talk about sort of the role of calcium, where you guys all think it fits into a resuscitation like this? What are our triggers for it? And then particularly the difference between calcium gluconate and calcium chloride, and sort of the operationalization of those two.
I can bite first. Anybody want to go?
I could try, but I don't have a great answer.
All right, go for it.
I think that we all agree that calcium is needed. And I think that everybody is recognizing that calcium, not just the overall calcium level, but it's important to a lot of clotting factors that were unappreciated before. I don't know if we know the exact amount in terms of, protocolizing it in terms of massive blood transfusion protocols at this point. I've heard different things thrown out there. If you want a little bit more volume, you can do your calcium gluconate. If you're trying, if you have this person had that huge line in. You want to go ahead with calcium chloride, you know, and get more bang for your buck. I think that's appropriate. I don't know if we know the exact proportion yet for these patients.
Good. I agree. Generally speaking, with massive transfusion, or after we start giving at least somewhere between 4 to 6 units of packed red blood cells, is when I'm thinking about giving calcium. You have that citrate effect, right? When you give multiple blood products, and you're going to, as a result, lower your calcium level. Calcium is a natural pressor, like an inopressor in of itself. It'll give you some blood pressure effect as well. And, you know, once we're getting around that 4 to 6 unit mark is when I'm pulling out the calcium. For somebody who is this critically ill, and I'm doing a lot of things, or my team really is doing a lot of things, and I'm asking them to do a lot of things, I would like to try to simplify stuff, and I'll be asking for calcium chloride here. It's, you know, again, roughly 3 to 1 versus the gluconate. It's an amp they have to push here versus 3 of the calcium gluconate. It's quicker for them. You know, you certainly can give it peripherally, obviously, as long as you have a patent good working line. Yes, we prefer to give it centrally if you have central access, but in this situation, if you have a good large bore peripheral IV, totally comfortable with them giving calcium chloride.
So I'll take a calcium bite too. This is another one of those things where we have these patients on the edge of physiology, and the data, I agree, that's well said. We don't have any randomized controlled trials to figure out who does this, nor do I think it's going to be easy to get an ionized calcium and titrate these patients adequately en route. So I think when we talk about these patients that are actually dying, and we're in this sort of difficult to fix box, I think there's 2 things. Number one is calcium, we know, is a cofactor for a variety of elements in the coagulation cascade. It may be reasonable to give it early. I think our massive transfusion protocol at the you know, universal galactic shock trauma of excellence is usually after the 4th unit for a variety of reasons. I think there's also been data since the 1990s about, and I think Sean put this in the chat, that it has a positive inotropic effect, and it's been studied in various case studies for CHF and other areas where contractility is impaired. So I think when you're at the end of your physiologic rope and we're having problems sort of optimizing patients, it may be reasonable, number one, in that trauma setting, and number two, for these, you know, CHF, these poorly decompensated cardiogenic shock patients, I have not seen the downside to giving an amp of calcium gluconate in these patients who are in extremis, because there is also a little bit of data to suggest that it may help with contractility.
Dr. Margolis, question. Yep. Or actually, I guess anyone can answer this, but specifically targeted to Dr. Margolis. So, you know, you give your couple units of PRPCs, you're doing massive transfusion, you're doing your 1-to-1-to-1. How often are you giving calcium? Are you doing it every round, every second round?
Usually, so again, I'm trying to do it, again, no randomized trials. I'm trying to do it after every 4th to 6th unit of blood that I'm giving within that 1-to-1-to-1 scheme.
Gotcha. So that's a lot of blood product.
You're giving a lot of, yes.
Between calciums. Okay. Yeah, I don't think, I was just quickly looking it up. There's really no consensus on this.
Everything we know from the national. Yeah, I was going to say the closest that I know of is data from the National Trauma Data Bank that ICALs, you know, less than 1.05 are associated with poor outcomes, and ICALs less than 0.9 are very clearly associated with mortality. Now, whether that's a modifiable risk factor with the calcium is up to anyone.
Yeah, I think that's a great point. I mean, you know, we can't deny that that there are some positive aspects, and I think when we talk about these patients with no other option, just like with TXA and GI bleeds, we know that some of the studies show either equivocal or outcomes that aren't necessarily very positive, but the patients in hemorrhagic shock or for certain select clinical situations, you know, the benefits kind of very slightly outweigh the risk. And we're talking about a very kind of measured calcium administration. I think as long as we don't forget it and keep it in our back pocket as a tool for these very specific decompensated kind of situations, it may be something that we can consider for patients with few other options.
You would agree that hypercalcemia would be preferable over hypocalcemia in these situations? Yeah.
I love the military CPGs are publicly available for things like burn and a lot of other things that are always kind of nice to go over a very down and dirty protocolized method.
Good deal. Well, I think this has been a great discussion of these points. We could probably keep going round and round about this stuff for a long time, but I think we'll move on to Meg. If you want to talk about, essentially, this is what we ended up with post transport. So, like you said, the patient was getting a massive transfusion when you got there, and looks like they were transferred down for a TIS procedure but didn't survive. Do you have any more details you want to add on that, or is that pretty much all we know?
No, that's all I know. I never got a chance to actually look at the chart before it disappeared. So I went to go look at it last week and never got around to it. But yeah, I'd gotten word that the patient had died relatively shortly after arrival. So I don't have anything else to add, unfortunately.
Okay.
Yeah, I one thing to add on that, Sam, real quick. Maybe
Yeah.
Meg already talked about this, but you guys mentioned before about sort of blood product availability, and sometimes we're going to other places and they don't have platelets, or they've already used up all the blood or whatever. Well, with this, I remember this case. I actually met Meg up on the helipad to help him get down to the floor, and I don't know if she mentioned this or not, but when we got down to the MICU, there was going to be a delay in how fast they could get their massive transfusion blood up to the unit. So we actually used the aircraft blood. They have been transfusing some blood from the sending facility, but we actually used the aircraft blood to give them more blood until the massive transfusion arrives. So sometimes it's not even just the availability at sending facilities, but it can be logistics here too.
Sean or Meg, do you know which access point they use to give the blood? Were they doing
dialysis catheter, which is huge.
Yeah.
I was gonna say they used a vein, but yeah, I don't remember.
That's definitely correct.
All right, great. Thanks, Meg. Thanks everybody for that one. We're going to move on to the second case here, which was a cardiac arrest with ROSC. So here's your dispatch: 31-year-old female, 120 kilos, going ER to the CCRU. PA arrest, intubated on a couple drips. So just like before, what are your thoughts as we head out the door on this patient? What do you want me thinking? What do you want the crews thinking as a medical direction panel? What do you want us thinking as we head out the door to go get this patient?
The thing I would say would be prepare for this patient to arrest again.
Okay.
Have everything in place, planning that this is going to be, another cardiac arrest, because, there's a critically ill patient. So get the Lucas, get everything optimized.
Did that say a 30-something-year-old female? Is that what it said?
What was it, Cody?
Yeah, 30, 31, something like that. Yeah, it's 31.
So pretty young. So young female, cardiac arrest.
Yeah, I would like to know the underlying pathology as quickly as possible, if known, because obviously there's most likely reversible cause here that we need to get to, and the underlying physiology. The sooner we know, the better we can get this patient, and like Eric said, hopefully try to keep them from arresting multiple times. Transport.
Sure. Does the downtime matter? Does the fact that they're being cooled matter? Like, are those things something that I need to be asking when I get there?
I think that's a great question, Sam. And I don't have anything to back this up, but I would assume that somebody that has a prolonged downtime is much more likely to re-arrest on you, just because of the cumulative effect of the ischemia, and the difficulty with the resuscitation. So I would say that, although these patients are extremely sick, the patient that's had the longer downtime is going to be even sicker than the one that was, shocked out of VF immediately.
Okay.
At the risk of introducing even more controversy into this collaborative, not a big fan of, this issue of cooling. Like I would much rather, if there's a question about it, we should probably defer that until we get this patient stabilized. I mean, not only just cooling, have lots of issues with blood pressure and platelets. I don't think we do it very well unless we're doing it invasively. I think a lot of these patients will assume room temperature for the reasons that Sam mentioned as well. They're being ventilated with cool air, they're getting IV fluids. And remember, cooling is great. It can be neuroprotective, but you've got 6 to 8 hours of time in order to initiate it. And I think if you have a patient that is very labile and marginally hypotensive, you're introducing another barrier that we can poorly control, or another variable that we can poorly control into the whole transport synthesis, when we could just defer it until they get to definitive care with either an appropriate catheter or a correction of any underlying cause.
Here, completely agree. These patients are going to be cool. I mean, rarely are you going to get a post-arrest patient who's, unless it was secondary to something environmental, who's going to be really hot. I think, again, when you resuscitate, again, their clothes are off. You're giving them fluids that are below room temperature. You're doing a lot of things that are causing their body temperature to basically cool already. I think the key here is don't let them get warm. That's really what I'm focused on, more so than actively trying to cool them, because a lot of times, again, they're probably going to be cool already. And our ability to really assess accurately and continue to monitor, as Dr. Launer said, not great until they're somewhere where that could be done and sort of focused on.
There are probably a couple of historical factors, if we can obtain, that would be very helpful as well from a prognosis and trajectory perspective. Witnessed versus unwitnessed, bystander CPR, if this is an out-of-hospital arrest, initial rhythm, are all going to be important information that will come in handy in the very near future, notwithstanding the immediate stuff already discussed.
Good deal. Thanks, guys. So Cody, give us the case. Answer some of these questions that have been posed.
So patient presented to the ED with severe respiratory distress. This is about midnight-ish, 2 o'clock in the morning time frame. Her room air stats were in the 70s. Shortly after she gets to the ED, there was a witnessed PEA arrest. They got ROSC right then. During the course of her ER stay, she had 6 to 7 subsequent rearrests prior to the crew even getting there. So they put an ultrasound probe on the chest and found RV distension secondary to a massive PE.
There's your answer, Ruben.
Yeah, I mean, this I know there's a cardiac arrest and PA, and there's like an established algorithm, but knowing that this patient is in massive right heart failure from obstructive shock really does help out in terms of what medications we have available to us, and kind of, I know people feel a different way, but pressor choice and fluid administration and things, these things do matter if we get ROSC and we're trying to pressure support, support their pressure. Knowing the underlying physiology really does help.
Good deal.
Conceptually, I really have an issue managing all PEA arrests the same. I always have. PEA arrests should not all be managed with old school epi and atropine, and now epi. That is just bonkers. And we could have an entire discussion on how to manage different types of PEA, pseudo PEA, slow versus fast PEA, narrow versus wide PEA, PEA secondary to a known underlying cause such as a massive PE. I think we 4 rounds of epi, right? I think we really do ourselves a disservice just trying to fit PEA into an algorithmic box and managing it the same way. It is just a nightmare, and something that is bound to get you in trouble and not really be the right thing for your patient.
As Cody Winifred would say, it won't get you out of a jam.
Exactly right. Okay, so.
Sorry, Cody.
Oh, you're good, man. So obviously, patient's intubated. I can't see the top line there. So she's intubated. She's on some pretty vanilla vent settings. Tidal volume of 400, rate of 20, PEEP 8, 100% FiO2, about 8 a minute volume. Presentation, she's in sinus TAC without ectopy. She's pale, cap refill slow. Her maps are okay, 80 to 100. We've got 18 gauge access on the right hand, 20 gauge left AC, and a right fem triple lumen. And she is completely neurologically not responding to it. So she's DCS at 3, sluggish pupil response, RAS -5. And she's really, she's only on, if she was, yeah, no, she wasn't on propofol or anything for sedation. So we kind of got our guard up a little bit about how well this is going to go. We get to the bedside about 0420, 0419. We're there for a little bit, I think, just trying to get things changed over. She's on levo, she's on epi, she's got a heparin drip going. She did get a heparin bolus. She did get TPA prior to arrival, and also 2 liters normal saline. End titles are looking okay. Her RAS is, again, is -5. SpO2s are looking decent. I'm happy with this from knowing that this is a PE and I'm over 90. I'm like, good, okay, I'll take that. As far as gases, I couldn't pull one out of the chart. I don't think we had one, but we do know we've got a gap of 29. So things aren't looking all that great for us. We'll go to the next. There we go. So for transport,
sorry, quick question for you. Just go back to the last. Yeah, the TPA. How was that? You may not know the answer to this. I'm just curious. How was that given? Was it given as 250 milligram boluses over like 2 minutes or so? Was it given as 100 as a single bolus? I'm just curious as to how it was given.
That's a good question. I just looked at the HPI again. It's not in there. My assumption would be that they gave that 100 milligram all at once.
Okay.
That would be my assumption.
Is that the question of half dose versus full dose TPA, Asa?
Yeah, I mean, different places do it differently. In cardiac arrest, I know we tend to give 50 over 2 minutes, followed by a second 50 milligrams over the next 30. That's how it's protocolized. Some people give, the 100 over a few minutes. Some give, 100 milligrams over 30 minutes. It's protocolized differently in different places. So I was just sort of wondering how it was done there. It's another sort of interesting discussion point.
All right, so for transport, we don't really do a whole lot of vent stuff with this patient. We put her CMD plus, respiratory rate of 12, a tidal volume of 530. We're getting about 510 out. Kept her PEEP on the lower side at 8, PIP of 24, minute volume at 6. Again, so the 2 things that I'm thinking about going out the door: 1, she's going to rearrest, and 2, if we don't get our vent strategy under control, that's going to be the #1 cause of a rearrest. For us en route, everything maintains, she maintains hemodynamic stability, a little on the tachycardic side, but SpO2s are looking okay, or end titles are looking okay, still RAS and -5 despite 0 sedation, no propofol, no nothing. We didn't change her levo doses, epi doses, or her heparin doses. We kept everything nice and even for the flight. And yeah, so go ahead, Sam.
Yeah, so now that we've kind of got the story, a couple things that we wanted to kind of talk about with the sort of the approach to this patient and sort of goals of care. We'll start like we always do. What are you sort of, is there a blood pressure goal in this patient? Is there a stat goal? Do we have a vital sign goal that we're sort of targeting for this patient other than just them having vital signs and not being in arrest?
I don't think there's a particular vital sign goal that you're looking for besides perfusion, like we typically would, like MAPS of 65. I would caution. So this patient got 2 liters of fluids. I would say vasopressor should probably be the first go-to, and avoiding additional fluids, because if this is the right ventricular failure, and the more ventricular pressure you have in the right ventricle, the decreased perfusion you're going to get. So I would say that we would treat this patient, I don't think, any different than we would in a typical really severely critically ill shock patient.
I just want to say I hate the right ventricle. I don't I don't like when the right ventricle fails. I think it absolutely sucks and it's selfish and it doesn't care about whatever else you're doing. So this is another case where, how do you protocolize a patient who is hypotensive and hypoxic due to a fixed perfusion deficit? So I agree with the temporization of the patient, totally agree with the lack of goals. And we've unfortunately had some good experiences with these patients because we accept all of them for ECMO evaluation, regardless of their 7 rearrests. So I think our goal is to try to at least have some degree of perfusion. So if you can have some type of consistent level of oxygenation, which is not at the arrest level where you have signs of perfusion and the lactic acid at least isn't decreasing. We've actually had some results with this. Interesting, I totally agree, vasopressor strategy where you can start with norepinephrine to basically cinch off the tank and then consider epinephrine for a small degree of forward flow, because a big problem with these patients is that they've got this obstructive shock and then you've got resultant cardiogenic shock or RV failure. And sometimes the epinephrine is necessary in order to drive some of the stuff sort of forward and generate a perfusion pressure. The other thing, which is going to be talked about here, I would suspect, is that we've had some good results with inhaled prostacyclins for these patients that cannot oxygenate for some degree of pulmonary vasodilation. This is just another case where, remember, in the setting of PE, unless you have somebody there that can take out the clot, put the patient on ECMO, or do a median sternotomy and do an embolectomy, we're really trying to temporize the patient. So again, it's what can we do within our limited, but yet I think fairly filled toolbox to temporize a patient's circulation. And I think that's where we have to look very carefully, and Cody said it, is try to optimize the ventilator strategies as best as possible, and then using a vasopressor strategy that kind of complements their already compromised circulation. But yeah, very difficult patient.
You
5
were
amps of bicarb.
I love you, man.
You're stealing my thunder, Launer.
Really, I love you, man. Great thought process. I was actually going to bring up something similar and maybe throw it out to the group. So there's something else we haven't yet considered, although Dr. Launer just did. In addition to vasoactive medications and trying to find that right balance between norepinephrine and epinephrine, are there pulmonary vasodilators that we could deploy here in this patient early on? And where does that fit in sort of the care of the patient, getting them, temporizing them to get to what we're trying to get them to, which is ultimately, ECMO cannulation. This would be another example of, yeah, we all know INO and inhaled epoprostenol doesn't necessarily change mortality, but that's not what I'm looking for here. I'm looking to stabilize them, to perfuse them, to get them to what they need. So I'm just curious as to the group's thoughts, and I could certainly weigh in as to when we would consider deploying something like an inhaled pulmonary vasodilator. In our case, it would probably be INO first, especially in this world of COVID where we can't find inhaled epoprostenol to save our life. But what the rest of the group thinks.
I was gonna be the third person to bring this up. I think INO definitely. I mean, you're going to cause pulmonary vasodilatation. You're going to reduce the workload on the right ventricle. But I guess the question I have though is if you don't have ultrasound, right? I mean, unless you ask the ED to do that. So you have, I mean, we know we have cardiac stunning and cardiac arrest. We know we probably have poor LV function. Is that going to cause you to hesitate, or are you going to say, well, the risks outweigh the benefits here, and they're intubated on positive pressure ventilation anyway?
I would just say, I think unless left heart failure you think is the cause of while they're sick, I'm kind of a profligate Velitri user in these patients, even if it's a little unclear, like they're immediately post-arrest, they have RV dilatation, they're waiting for a scan, but they're still unstable. I think the thing to know about Velitri for people who don't use it a lot is in left heart failure, it can cause overload of the left heart due to the pulmonary afterload reduction. So if you have like your group 2 pulmonary hypertension people, that's at least a relative contraindication to Velitri.
Yeah, I would agree. In this patient, yeah, she can get some. We already know she has right heart failure. You can get, I guess, some biventricular failure in post-arrest stunning, but left heart failure is not her primary issue. So in this patient, I would use it. without really sort of thinking twice about potential primary left heart issues. I agree, if it's a primary left heart problem or you have echo evidence to suggest left heart failure, then obviously you can make them hypotensive and make them worse by initiating this pulmonary vasodilator therapy.
All right, so I have a question for the group then. I'll bite here. And maybe I just brought a knife to a gun show, not to a gunfight, I don't know. But so if we're talking about initiating INO in this patient, what's our Sam, what was her, or I'm sorry, what's our flight time? What's our time back to where we're going to university?
Cody, this was upshot, right?
Yeah, 15 to 18 minutes.
15, 18 minutes. Okay. All right. So, and with those vitals, I guess my question for the group is, what's the lesser of the two evils at this point? Is it to do it, or is it to go knowing that what exactly Asa said a moment ago? This is it's temporizing. I guess if they're rearresting again, they rearrested 7 times. We'd all agree that we have to do something. But I think it's a real-time judgment call.
So my question along those lines, and this is sort of off the INO question and more to the time question that I think Dr. Levy's bringing up, is there such thing as too unstable for transport in this case? Does it matter? Do I move this person with Lucas running? And I hate to say this because I hate this, but do we scoop and run on a patient like this? Do we just snatch them up and take them to trauma and give the CCRU a heads up that they need to be crashed onto VA ECMO? Like, what's that thought process?
Great
Cody,
question.
No.
Go, Eric. No,
I was going to ask it, Cody, was this patient going to the ED to an ICU and was going to be managed in the ICU, or were they going to get ECMO, or did they have what was the plan when they got to university?
CCRU, baby.
Yeah, the plan was CCRU, and the assumption being VA ECMO.
Gotcha. So this, I would sort of put this in the category of what we call the RIT, or the rapid intervention transport, right? And there are certain rapid intervention transports that we need to think about, because sometimes stability is only achieved when you get them to what they need. And, getting onto VA ECMO is one of them. I think you need to balance it. And I think you need to be doing the things to help stabilize the patient as you're moving. This is very different than the ICU to ICU transfer, where, you could spend a little bit more time and we're not necessarily offering them additional therapy other than sort of additional expertise and in a bigger ICU to manage the patient. Here, we're actually getting them to an additional procedure or therapy that could be life-saving. So it's not do nothing, because if you do nothing, you're going to end up with a dead, unable to resuscitate patient. But you need to do stuff as you're moving with these individuals, which is why practicing this kind of stuff, making sure that we know how INO works or the inhaled Velitri, getting them on this equipment pretty quickly can be done efficiently. So we spend, certainly less than 20 minutes at the bedside with these rapid intervention transports.
So let me, I agree. Let me just add one thing here. And if I go into cardiac arrest before the end of this, because the CCRU gods heard me and there's some evil mojo about. So the CCRU's answer is that hardly anybody's too unstable for transport. We can take somebody with literally a heart that's externalized, but if they're going to crash them on ECMO, we will save their life. It doesn't matter whether they have a left main that's even intact. Now, I've been on all these risk safety calls, and it's very frustrating because the CCRU is only helpful if you can get there. And for those of you that know the University of Maryland, you've got to go to the ambulance bay. You've got to transition up 2 sets of protected elevators, all the while doing your INO, your transport. Now, we've perfected this. Now, I think it's exactly as Asa said, is that we, just like with safety, we have to have a discussion about risk benefit. So for the patients that have had rearrest, and I don't know what your trigger is, rearrest, a bicarb greater than 22, all of these cases, where when the patient is that sick and we worry about movement, we have to have everybody on board to agree that, we're going to give them something. And I'm all for taking the risk as long as we understand what the return is at the end. And I think all too often we say, either somebody is very busy and they say, yeah, just bring them over. And that bring them over in what we do is a very difficult situation, right? It involves a lot of technical and logistical expertise. So I make sure I tell my crews, again, I can't protocolise this, but for the patients that are absolutely sick, it's not, they're peri-arrest, I say, look, even if they're going to the CCRU, we'll crash them on ECMO, I want to make sure that that's the plan, that we're to give them some type of definitive therapy over that what they would be receiving at the outside facility, so we make the risk worth it when we are engaging all these resources. And I think that's just being responsible.
I have a question from a flight crew perspective, and Sam, jump in on this one. So with respect to the question of too sick to transport, and in this particular case, does having a Lucas or not having a Lucas make that decision for you?
It helps me make that decision. I've been in these situations and I've asked the fire department for the Lucas. I said, can I steal your Lucas? I'll bring it back to you. And half the time they say yes, and half the time they say no. I'm not going to commit to doing manual CPR for 10, 15 minutes. If I have a Lucas, potentially yes. That's just the way I look at it. And if I'm going to the CCRU to get crashed onto ECMO, then I think it potentially in a 31-year-old might be worth doing. But I'll defer to the panel of folks who are far smarter than me.
Love the Lucas. Bring the Lucas. Lucas makes everything better.
We'll ECMO the Lucas device, Michelle. It's okay. We'll probably figure out a way to give that blood as well. We'll figure it out. Just bring them over. We don't care.
We put a Lucas.
Except at Hopkins. If they have a pulse, no ECMO. If they don't have a pulse, no ECMO. If they have two eyeballs, no ECMO. So I don't know.
So I'm gonna.
Oh no.
Oh
Here
God.
we go.
So yeah, so we actually have an ECMO Go team now from the fellowship. We go out and we cannulate. We use Medevac 10. We take the fellows. We go cannulate to different hospitals. It's a new thing we're starting here.
Are they kidding?
Yeah, that starts tomorrow, right, Asa? I'm all in. Yeah.
That's right.
Lucas is ready to go. So just because we can, just because we can.
Well, I mean, this is getting a little bit off topic, I guess, but they're doing this. The folks in Minneapolis are absolutely the pioneers on this, and I think it's something that I'm interested to watch happen.
Well, so I think you've just, Sam, there's no shortage of controversy and ammunition here. So there was another grant that we just submitted, and I can, I'm sure Bill Teeter, one of our CCRU attending fellows, heads will explode when we talk about this, but as you know, there are so many different considerations for how this works, and I think not a lot of consensus, but I think we can do it. And you're absolutely right that Minnesota had a proof of concept, but there's also, $10 million attached to that proof of concept. And there's other things where institutions have to collaborate and talk to each other, which I think is great. So I think that would be ripe for a whole other discussion about, what resources can we bring to the patient and what indications, because it is possible.
Minnesota has a really great sort of set of circumstances that allows it to happen, including external funding, including a champion being the person that's putting the people on ECMO. The problem I think we have is we can't put people on ECMO and take care of them as emergency department physicians. But I'd love to do it. It's such a great. I think it would be very tremendously helpful for our patients.
I'm gonna shift gears there a little bit. Let's say this lady, they called us early, or she got decompensated, and we get there and we are forced to intubate her. She, from a mental status, is decompensating. From a hemodynamic status, is not decompensating. We've got to control her airway. We're not going to be able to move her. Let's say it's further than upchuck. Let's say we're going a 30-minute hop. So I'm forced to intubate her. How do I do it best? How do I optimize her? All of that stuff.
I just
don't intubate her.
Don't intubate her. Okay.
Don't intubate her.
So that is the person we're going out and cannulating in situ makes the most sense. That's why this concept is something that I'm interested in particularly.
Absolutely.
It's funny because we've had this case, and we actually had a transport re-debriefed, and I believe our crew ended up bagging this patient, which is also not at all helpful. So I'm mindful of the fact that sometimes these patients need to be intubated, but we also want to make sure that we're intubating them for the correct reason. We're not intubating them because of their horrifically low O2 saturation. We're intubating them because of a work of breathing issue and hemodynamic instability. And if your choice is, the patient's going to die, it's very difficult to, bag somebody effectively for 30 minutes who's this sick. So I think, when we talk about push dose pressors, you may also supplement with some peri-arrest bicarb. I think there's a couple things we could do, maybe even add some vasopressin just to temporize the hemodynamics because they have no reserve. The other consideration being awake intubation, but the bottom line is none of these things have their basis in evidence, because once you make that decision to intubate, just like a COVID patient who requires invasive ventilation, you're already dealing with somebody who is really moribund, as opposed to just moribund, which would be not as moribund. We'd ECMO that person too, probably.
The only contraindication is rigor.
Rigor. We won't ECMO rigor. That's good.
Not yet.
I don't know. I'd love to hear. I mean, we've had this case. I know Michelle is one of our crew members that actually had this case where they were arguing with one of the CCRU physicians. It's not easy. I mean, yes, it's easy to say don't intubate, but I always want to empower our crews to do the best thing for our patients, but that also means they need to be prepared to think outside of the rigid box, right? And intubating a patient with right ventricular failure and hypotension, we already know what the outcome is likely going to be. So this is where you've got to maximize again to the extent possible. And there's not that many evidence-based tools, right?
So talk to me how you want me to optimize this patient. Like I have to intubate this patient. Like there I have no other choice. I'm backed against the wall. I have to do it. Well, how do I optimize the patient? Multiple push-dose pressors, some pre-intubation bicarb, really quick intubation, like very little positive pressure before the intubation.
Minimize apnea time.
Yeah, I think it's being, if you're in a situation where you truly have no choice, I think getting your pressors in line, expecting an arrest. So if they have not received TPA, just have TPA ready. I'd go so far in some of these patients to mix it up. The company will actually reimburse if it's not used, at least in most hospitals. And then obsessional pre-oxygenation and very minimal positive pressure. So I get these people on high flow or BiPAP. I use ketamine. I do not paralyze them. And a fair bit of prayer and hoping that their hemodynamics will tolerate it. But especially when they're obtunded in that situation, that's shock. So minimizing your dose of RSI, I give 25 milligram aliquots or 50 milligram aliquots of ketamine and keep them breathing.
Yep, I agree. I would start with probably, as he said, 50 milligrams of ketamine. I'd sort of calculate what like a 1 per kilo dose is, not necessarily the 2 per kilo RSI dose, but have an idea of what that is. Break it up into, I've done 50 milligram aliquots, not paralyze them. Again, you're intubating them because they are so obtunded that they literally cannot protect their airway, and they may aspirate. Or their work of breathing is just going to get them into further trouble. So you don't need a whole lot for these patients. That's one. Two, completely agree with the concept of inline pressors. I would do that over push dose pressors. I'd rather you not give push dose pressors. I'd rather you put your pressors in line and start some Levophed on these patients. Expect them to decompensate and likely need more. Agree with having your TPA ready for these individuals as well. And, if apneic oxygenation was ever a thing, it would definitely be a thing here. Even better if you have the ability to use high flow nasal cannula. But if not, certainly our nasal cannula underneath our non-rebreather, both at 15 liters.
So I guess that leads me to the other question of like, maybe this patient isn't as decompensated, but their sats are garbage. We walk in and they're on nasal cannula, they're on a non-rebreather. Is there an argument for transitioning them off of those things to high flow nasal cannula? And what is the role of high flow nasal cannula in the submassive PE, right? So massive, submassive PE to get them where they need to go. since most of us have the ability to initiate high flow now?
In my opinion, better than the non-invasive positive pressure ventilation, which would be BiPAP or CPAP.
Sure.
So I would choose high flow nasal cannula here to optimize oxygenation. Again, provided that was the issue. And again, it will take away some work of breathing. It will help with some work of breathing, not really to the extent that BiPAP or CPAP does, but it will help with some and reduce some work of breathing. So if it was really an oxygenation issue, that would be my my go-to here.
Totally.
Is there an argument to transition a lot of these PEs that from whatever oxygen therapy they're on to heated, humidified high flow, off of nasal cannula, non-rebreather, whatever, to heated high flow to decrease that work of breathing?
I like it.
Okay.
Yeah. I think the thing with the massive PEs is right their work of breathing is from their obstruction. The BiPAP is not going to help you, significantly, because the reason they're looking like crap is their respiratory drive is off the charts because they're not getting pulmonary blood flow. And so anything you can do to optimize VQ matching, which in my mind is typically going to be high flow nasal cannula, is going to be the most helpful thing.
Okay.
Yeah, I think there are zero arguments against high flow and nothing but pros, because like you were just talking about VQ mismatch, you're going to start decreasing that pulmonary vasoconstriction. The more lung you get oxygen to, it's going to improve your RV dynamics, and every other form of oxygenation from, is going to give you pressure. And that's exactly what you don't want. So I think high flows, you cannot go wrong in high flow. I mean, these patients should just all be on high flow.
Yeah.
And if I don't know if we're going to talk about it or not, but since we're on the topic of intubation, I was a little surprised at the vent settings for this patient. With the PEEP of 8, with RV damage there. I don't know if the patient needed that. I think their BMI was elevated, so I don't know if they were trying to, compensate there. But the PEEP of 8 was interesting.
Go ahead, Cody.
Yeah, I was thinking, so she was large, a lot of weight on the chest. Went with a little bit higher PEEP strategy just to kind of overcome that mechanical, atelectasis, for lack of better terminology.
I think, this is where using your CSTAT, your static compliance, could be quite helpful in optimizing what your PEEP is. I think, Ruben, what you were getting at is, you don't want to have the PEEP unnecessarily higher than you need it. In this case, maybe she really needed a PEEP, and that was it, and that was the best we were going to do. But I think we do have some tools like our CSTAT to help us figure out, what their optimal PEEP would be in this situation. And again, we've talked about, not only using CSTAT to go up on the PEEP, but using CSTAT to come down on your PEEP to figure out where they should be.
It's almost the exact opposite of our strategy for the ARDS patient, where we want to run a high mean airway pressure strategy. This is almost the exact opposite, correct? Where we want to run more of a low mean airway pressure strategy. All right. Well, I think that about kind of clears it up. I think we've talked about this stuff. This discussion of transport with the Lucas with and without, and then TPA. Is there a contraindication to TPA if you're going for ECMO? Apparently not with this patient, but if they haven't gotten TPA and I'm headed to University or Hopkins to get crashed onto ECMO, is the TPA still worth giving, or does that make life more difficult for the CT surgeons that are trying to cannulate this person?
I've done these cannulations. I can talk about it. I mean, having been in this circumstance and done some of these cannulations, our preference is, if we've sort of mentally committed to cannulating, is to not give the TPA, because we find excellent outcomes from BA on heparin alone.
Okay.
So unless your hand is forced, then our preference is to not give it. But obviously, if they develop massive PE or arrest, then you're stuck, and we would still put those people on.
Okay. Yeah, I agree. I sometimes think the decision point here is the arrest, right? I guess the other decision point is your out of hospital time. If they're so hypotensive that they're about to arrest and your out of hospital time is, 18, 15, 20 minutes, or more, then again, your hand may be forced. But if not, if you're maintaining them on vasoactive medication, and they haven't arrested, I would hold on the TPA, even though by textbook, they mean massive PE, right? And by massive PE, we're supposed to give, we can give TPA. If they're going definitively for VA ECMO and they haven't yet arrested on you, I would hold on the TPA.
Great, good to know.
Difficult place to be.
Yeah, these people tend to do quite well on VA ECMO. We've expanded our indication for massive PEs because they do so well. And often if there's problems with TPA, it's related to intracranial hemorrhage. As long as they are still getting at least some cerebral perfusion, we have a pretty strong preference to not give TPA if we feel like they're an ECMO candidate.
So this is when you take the TPA from the sending physician and you say, yeah, I'll give it in flight, and then don't give it. All right, so just to kind of close the loop here, this is the course of care for this patient. So good job, Cody. Snatching people out the jaws of death.
Well done. Very good, guys.
All right, thank you everybody for joining. I think this went well. Please send any suggestions you've got, anything you think went well, anything you don't think went well. We'll make it better for next time. I really appreciate everybody joining along, and hopefully we'll do this again soon.
Yeah, we'll plan. Thanks again, everybody. This has been so well received. I know it's been speaking on behalf of our crew and everyone else, and it's excellent. I think we can even expand it as we talked about. So I really appreciate everybody's time. It's been great. So thanks all.
Wildly successful, Sam. Kudos to you as always. Excellent job. University team, thank you so much for joining. Dr. Launer, you are always my hero.
You're mine.
It's great to see you guys. That was a lot of fun. Thank you.
All right, everybody.
See everybody.